Everybody, so the next section of this chat is going to be covering a few little topics. We're going to first hear from a video from Kate Granger on Hello, My Name Is, and we're going to have a little bit of a chat about that, and then we're going to be looking at Last 1,000 Days and EndPJ Paralysis. I'm going to start it off with a little video from Kate.
Hello, My Name is a social media campaign that I launched last year after my experiences as a patient in hospital with a post-operative infection. And I noticed during that time that many staff from all the professions and all the support staff forgot to introduce themselves to me when they were delivering my care or interacting with me. So this was me. I'm 29 years old. I'm happily married to my husband Chris. I've got a successful career as an elderly medicine registrar. We're just thinking about having a family. We're on holiday in California. An idyllic life, you'd think. But 2 days later, I was admitted to hospital in the States, acutely unwell. And the reason for my acute illness was that my kidneys had failed. And the reason for that was that my abdomen and my pelvis were full of tumours. Bang, out of the blue, age 29, I had cancer. I have a very rare type of sarcoma, and it affects my abdomen and my pelvis. And because of that, I have stents that drain my kidneys, because my ureters are blocked. And as part of that condition, the stents have to be replaced every so often. So in August last year, I had an operation to replace those stents, which went very well. But unfortunately, 36 hours after I got out of hospital, I was readmitted with a serious post-operative infection. I've had a lot to do with healthcare in the past 3 years, and I've reflected and observed that healthcare keenly during that time. Hello, My Name Is was born out of a hospital experience. I had the stents that drain my kidneys replaced last year in August. Uncomplicated, straightforward surgery, but 36 hours after my discharge, I was back in hospital with a high fever and a low blood pressure. And there, my experience of healthcare and people's interactions with me, I keenly observed. And one of my main starkest observation really was that people weren't introducing themselves to me every time they did something to me. It went right through the healthcare professions, from doctors, nurses, healthcare assistants, housekeepers, everybody on the ward really. But when somebody did introduce themselves, it made such a difference to how I was feeling about myself. It made me feel more human again. As a doctor, it's the first thing you do when you approach a patient. But then I started to reflect on my own practice and wondering if I had actually introduced myself to every single patient I've met or forgotten. And I think anybody who works in healthcare will have forgotten at some point. So I just wanted to use my experience as a catalyst to try and improve care. And try and get healthcare professionals to think about the importance of introductions and aspire to do better. The response to the campaign has been phenomenal. It's gone across the healthcare sectors, it's gone across the professions. The logo's recognised at healthcare conferences. There's little clinical reminders in the workplace. People have used it as screensavers, they've put it on observation charts, and people have designed ward introduction boards with all the photos of the staff that work there. There's been selfie campaigns, it's been printed onto the logo's been printed onto lanyards and badges, and all sorts of activities have been going on. People seem to have taken this campaign to heart. It's really struck a chord because it's something simple that we can all do, costs no money and takes hardly any time, but it really does improve the patient's experience. It relieves anxiety, it establishes human connections, therapeutic relationships, and that all-important trust and rapport that we all aspire to achieve with our patients. I think the biggest surprise is that it really is such a tiny campaign, and how it struck such a big chord with everyone in healthcare. I can't believe that, you know, politicians right at the top of health are listening to what I've got to say, and people right at the top of the NHS know who I am and what I'm about. And that is surprising for a normal run-of-the-mill doctor who doesn't really particularly feel special about anything. And the powerful voice that I've developed as a result of being a patient is something that I'm quite proud of. I've just been doing a session with the students as part of healthcare in Wales, and they are a very enthusiastic bunch of young people who are the future of our healthcare. And I think if we get the simple things right for them now in their careers, that's going to bode well for the future of healthcare, really. They need to recognise the importance of things like introductions, the importance of person-centred care and what that actually means now in their careers, so that they take it forwards with them. My time is precious. I have a very limited prognosis. I probably only have months to live, although it's difficult to determine that. So I am very passionate about changing things now. So if I'm invited to come and do something, then I'll come and do it. My key message to all the staff in NHS Wales is that patients are people at the end of the day, and we should treat everyone that we look after like a member of our own family, or how we'd want to be looked after ourselves. If we meet somebody in the street, then we introduce ourselves, we give them our name. So that should happen in healthcare as well. And I fully believe that if you do the simple things right, then the more complicated things just follow on naturally. And so get your introductions and first impressions right, and you'll be half the way to getting the rest of healthcare right.
Matthew, can you remember when you first heard or learnt about Hello, My Name Is?
Yes. It's been a few years ago, but it's when I was moving away from the clinical side of things, we started looking at it and started coming across it. It was one of those things that you sat back and reflected. I'd worked in recovery and ITU, and you think back and think, yeah, of course I introduce myself to every patient because that's important. And then you start thinking back about, did I really do that with every patient that comes in the door? Or do I presume that, do you sort of say hello to a couple of patients in a bay in the morning, and then you sort of presume that everybody else knows and go into side rooms to do things, and you don't really always introduce yourself? We've just had the same conversation from Dr. McCabe from Worcester Acute, how we refer to our patients with #CallMe. And it's such an important, powerful thing to a patient to call them the correct way, what they like to be referred to. And it's exactly the same with how we interact with our patients or anybody we meet. It's common courtesy and decency. You wouldn't, expect to go into anywhere else and not, your plumber comes and tells you who they are. Yet in healthcare, we presume and we do to people, and we need to move away from that.
My reflection on this, so I never met Kate in person, but literally I remember one evening on Twitter scrolling through my timeline and finding a tweet from her in hospital at this time when she was talking about how dreadful she was feeling and how people weren't explaining who they were. They weren't introducing themselves, and how isolated she felt. And I read that and I started communicating with her on Twitter. And it was so powerful, because actually this is just a fundamental human courtesy this is how we react outside of hospital to the people that we meet. So why should we suddenly be distant from the very people that we are looking after? And we're meant to be empowering them, and we're quite often doing really intimate things to them, and we haven't even told them our name. They may be able to read our name badge, but that might be covered by an apron, or they may not be able to read it. So actually, it really struck a chord with me and made me reflect on something that I have tried within my practice as a nurse, to always try and think, if this was me, if this was my mum, is this good enough? And if the answer is no, I might not be able to change it right now, but I can't just forget this. I need to make this better. And it's kind of, and this is such an important thing. I think it was brought home to me many years ago when I was working as a clinical nurse specialist, and a patient who had been in my ward for many months went home, and after this period of time wrote a letter about her experience. I think she was in hospital for 7 months, to the chief executive, and the chief executive rang me and said, "Oh, you've been mentioned in this letter." And I said, "Oh yes, Mrs. She'll have told you that as the stomach, I was the only one that could make the fistula pouch stay on. It would take me 2.5, maybe 3 hours, but then it would stay on for 4 days, and she had no leakage." And she went, "No, she didn't write that." And I went, "Really? But I was the only one that could do that." So she wrote down that one day when she was talking to you, she was telling you that her mouth was sore, and when you'd finished the procedure for her fistula bag, you went down to the hospital shop and bought a packet of ice pops so that she could, and you put them in the hospital fridge, breaking the rule because it said there could be no food in there for patients. You put a label all over it, you explained that it was fine, and she had these ice pops, and she remembered, and that's what she was saying. And when you think about it, of course I'm the clinical nurse specialist. Of course, it was natural. She would assume that I could do this clinical thing. What stood out was the fact that I bought her ice pops, that compassion, that listening to her, that little thing, and breaking the rules to put them in, that she probably had told many other people about her sore mouth. And they go, "Oh yeah, I'll see if I can get you some Vaseline," or whatever. And they hadn't done anything about it. And that made me really rethink what was important. And for me to coin this phrase, the little things are the big things. So that one thing she remembered and wrote in a letter to the chief executive that I put, and then of course the chief, and you put it in the hospital. Don't even get me going about the fridge in the wards. Yes, I did, and quite rightly so. So change the rules. I shouldn't have had to have broken a rule. This was the right thing to do. But isn't it when we reflect back, what I think is important or would have been valued by that lady was my clinical skill. Hello, I'm the specialist nurse. I'm going to do this. And actually, it was the fact that I was a fairly nice human being to her that day. I listened to her and I went and bought her some ice pops. And we need to re-evaluate what we consider important as specialists, as doctors, as nurses, because I think sometimes we get it wrong, as Kate identified very clearly for us. So yeah.
It's very easy. I know over the years I've dealt with some very tragic, horrible situations throughout the years, personally and professionally. And you put on this suit of armour, the nursing uniform. I am the nurse today. And you are being professional. And it's not that we're not being compassionate or caring, but sometimes we don't want to let that human side out. But those are the bits that really matter to our patients.
Yeah. Yeah, I agree.
Donna, did you want to come in?
Yeah, I mean, the thing I'm finding harder is remembering that you might have to introduce yourself 3 or 4 times that day, because habitually you'll start your shift, you'll go in the morning, you'll say, "Hi everybody, I'm Donna, I'll be looking after you for today." But you might go in 2 hours later and Mrs. Smith in the corner has got dementia and doesn't remember who you are, so you have to go back up to them again. And in my new role, where I'm an advanced clinical practitioner, it's really difficult because you're getting told that you have to empower the profession, show who you are. But most of our patients don't understand what that is, don't understand what a clinical nurse specialist is. And it's like, if I say I'm a nurse, but I'm more in a medical role, it's kind of like that balance. So I just say I'm now Donna and I work with the medical team. I don't care what I am, because I'll do anything in the ward. I'll pick up a mop if I need to. But it's letting them know they've got that name. And I'm really bad. I've got my old trust's name badge on because it's a "Hello, my name is" badge. My new trust doesn't have them. So it's having that and then covering up the trust name so it doesn't look like I'm an imposter. But it's having that visible sign to say, "This is me, my name is this," knowing who it is. Having been a ward manager, the number of complaints you had then who say, "A nurse did this and I wasn't happy." And it's really hard to try and say, right, describe the nurse. What was their name? Because they never get the name and they're trying to describe them, but being politically correct and kind of say, well, it's a male, he's got a ponytail, he's got this, and you're trying to kind of narrow it down who it is. And if you're lucky, it is a bald male nurse and you've got 1 on the shift. But if it's a tall blonde female, you could have 10 of them in your staffing and you don't know which one that needs to be educated. Or so it's really important, one, to get the praise that your patients give you as well, but also to help know who everybody is on the ward going forward. Otherwise they just get nicknames. I remember being a patient and I nicknamed every nurse in the ward had a different name. And I can tell you it probably wasn't the name that they were born with.
Yeah, okay.
The thing that worries me about this, Kate started this campaign several years ago. We all acknowledge how fundamentally it's essential in what we do, and the same with Mike's work, look at referring to our patients by the name they'd like to be called. Why are we not? What's blocking us from actually this being the norm? Because it should be. We acknowledge it should be the norm, but it's not. There are pockets out there of excellent practice. There are pockets out there of really good practice, but there are still pockets out there that haven't got it.
I don't know the answer.
No.
I know if you were to ask most staff, they'll say we're too busy, and it's just not good enough. And it's trying to get them away from that and trying to and that's the whole thing with FAB, is finding those quick wins that staffing's not the correct answer, because you can flood a place with staffing and all people do is they become lazy. They expect is that somebody thought somebody else was doing it and nobody ends up doing it, and that saying, which I can never remember, is the right way around. And it is the basics and the essential care. It's even like going back to this morning of the mouth care bit, and it's like, actually we shouldn't. Why is it 200 years after Florence brought in nursing, are we still thinking about mouth care and making sure people can eat and drink and the nutrition stuff that was getting talked about? Was that today? Was that yesterday? And it's the basics and essential care of how things are going. I don't understand why it's not getting embedded. Maybe we just need to make people work longer years and then we can just keep everybody at work, and then we don't have these new generations of nurses coming in with rubbish ideas.
Okay, I'm going to be a bit controversial here, because I think for nurses, and I'm not talking about any allied health professionals or our medical colleagues, but for nurses, we have a very passive language because we are originated from religious orders. We talk down what we do. So, for example, the things that in the 70s and 80s, I heard as a student nurse being referred to as basic nursing care, which was mouth care, which was the hygiene for a patient, which was enabling them to eat if they couldn't eat themselves. Actually, these aren't basics. These are the fundamentals on which all other care, nursing care and medical and allied health professional care is built. And unless you've got that foundation of these fundamental skills, but we don't, oh, it's just basic nursing care. There's nothing basic about it. And until we ourselves value the importance of it, then yeah, I'm not quite sure how we progress, because say introducing yourself and being courteous to somebody is absolutely fundamental to building a trusting therapeutic relationship with them. But I think the last 18 months with where the mask wearing has significantly made things even more difficult, because you can't recognize people often in a mask, and so it's really amplified the importance of very clearly with a sticker, or hello, my name is, big sticker or picture. I know many trusts they shared on Fab, they actually had photographs, and they have a photograph stuck on so that the person can see what they look like without a mask on. This is me. I'm sorry, I've got to wear the mask at the moment, but to build that kind of relationship, I think it's about what we value. Do we value the technical skills more than we value this real relationship building care with people that we are looking after? And I think that's a debate for nursing a lot, actually, at the moment, because you can still read papers published very recently that describe basic nursing care, and I want to screw them up in a ball and throw them out of the window. It makes me so cross, because it's the fundamentals. It's absolutely, if you haven't got that right, nothing else is going to go right.
And communication is one of the few things we can do as healthcare professionals while doing something else.
Yeah.
You can check a syringe, you can do observations, you can do all this while talking to your patients and introducing yourself. It doesn't limit you.
And not talking over your patients. That drives me mad.
Yeah. Listening.
But the mask thing does make a point. I went up to visit my gran, and it wasn't until I came out of the hospital, because she had delirium, that I got asked, well, did she recognise you? Did you know? And I was like, to be honest, I spent 4 hours on that ward because they had no restricted visiting. I had a good conversation with her about what I was working, what everything I was doing. But at no point did she call me by my name. And she didn't call me fat or call my hair was messy or do the normal stuff that she normally does. And I did have to wait until I saw my aunt the following week to say, did she remember me coming up? And she went, well, she did. And I was like, that's good, because I didn't introduce myself. I woke her up. I walked her out. I walked her to the bathroom. I walked her back. So apart from the fact I was in jeans and t-shirt, I could have quite easily have been a healthcare assistant on that ward just chatting to her. And it was that kind of thing. Actually, I didn't take my mask off, so she didn't know who I was. And I didn't say, it's Donna, wake up. I just let her wake up gently and kind of go through. So I think it was the nursing staff reminded her that I came up because they knew I was coming. So it was, but that kind of made me kind of think my practice as well, kind of going through and making sure that even if I'd been to see a patient in the morning, that when I go up to them again in the afternoon, it's like, do you remember me from this morning? Rather than doing the, hello, my name is Donna, because if you get that 3 or 4 times a day, they'll think you're a bit silly, you don't remember seeing me this morning. So it's kind of finding out how you get your practice in and get that bit so that they know that you've seen them before, you've jogged the memory of who you are, and then kind of thinking it through with that, because as I said, it might be the first time they've seen you that day, even though you've seen them 4 or 5 times walking in and out of the bay doing the tea round.
I was just wondering, I don't know if I've seen a very interesting comment in the chat that Kerry's written. I don't know if she wants to, whether she'd feel comfortable or wants to actually talk about it, but she's written in the chat that for someone who does spend time on the receiving end, I think in hospital, you know when the fundamentals are missing. And I think if you were able to talk about that, Kerry, that would be really insightful to what are the things that make you realise that care isn't as you would like.
I'm on, aren't I?
You are on. Yes, we can see.
I'm on my Surface Pro because I've been doing training today and I've got my blanket and my hot water bottle and whatnot. So I haven't got a mouse, so I was just struggling. So I've had some really poor experiences in hospital. Unfortunately, my husband is a nurse, so I'm just going to get that out of the way that, you know, I am on your side, and I deliver awareness training, disability awareness training to lots of trusts around the country, and, you know, Health Education England and RCN and all of those kind of people. So I am on your side. However, as a patient, I had an incident once where my doctor had seen my results at 6:30 in the morning and sent an ambulance, and I refused to get into the ambulance because of my past experiences in hospital. So there's a number of things, and this is the fundamentals. So I am a celiac and I am vegetarian. The amount of times I've gone into hospital and not been able to eat anything, or been given a lettuce leaf and, like, you know, or, you know, here's a jacket potato for you, and, you know, not a balanced meal when I'm meant to be getting better, or I'm on steroids and I've got a ravenous appetite, for example. I also have sensory processing disorder and have a number of disabilities. So the light and the noise and the smell and the bustle makes it very difficult for me to recover. It makes me quite anxious, uses a lot of energy, find it difficult to sleep. And also the times that I have been talked to, like bed number 1, and I've heard nurses talking about me at the nurses station, you know, that awkward one in number 3 or whatever, once the curtain's drawn. Well, I want the curtains drawn because it's the distraction and the lighting and the hustle and bustle is too much, and I'm trying to make a little bit of a cocoon. I'm trying to make my own environment. And so I refused, and my doctor called me in at 8:30 and said, "What are you doing? You're very, very unwell." And I'm like, well, one, I don't necessarily recognise I'm very unwell because I just keep going. However, when I explained that I've got a nurse at home, I could be in my own bed, which is, like, you know, good for my back. I've got my dog, I've got my children, my husband's an amazing cook, he can look after me all the time. I can do my environment. My husband wouldn't be able to visit me because, not now, but where we were, I was 25 miles away from the hospital, and he has no travel, so I'd be on my own. And I know not having any visitors is just completely miserable when you're in hospital. I've had times where I've had urine in jugs, 3 or 4 jugs of urine lined up on the side of my table because it hasn't been checked, and I'm in there for that kind of issue. And so those fundamentals, when you're sitting there looking at your own urine going, I'm in here because I'm horrifically dehydrated and ill, why isn't that not being tested? You know, and, you know, and it's all these small things that are the big things, as you say. And it's not that I'm not a particularly difficult patient, but my doctor said to me, right, okay, what we mean by bed rest is that you're in bed for 3 weeks at least, and you only get up to go to the toilet. So that's the sort of instruction I need as a person who has dyspraxia and ADHD, but you don't get that in hospital. You just get hours and hours of not being contacted, or you ask a question, somebody goes to find the answer and comes back and it's a different nurse, for example, and you go, oh, I was talking to so-and-so. Oh, no, they're on the other shift. I'm like, oh, but I asked them this. Oh, yeah, I'll go and ask the chef. And I'm like, oh, no, the chef's already been asked. Do you know what I mean? And I'm still sitting here hungry. So it's, you know, it is really difficult. And so when those fundamentals aren't in place, of food, of drink, of contact, of somebody understanding your additional needs, you know, it does make a huge difference. So I was on once with a student nurse, and I was actually doing a book review for a brilliant book. And she came up to me and she said, oh, I'm just a third-year student nurse. And I said, fantastic. I said, go read that book. Go read that book for your dissertation. It's a brilliant book, Helen Aviard book, doing a literature review, and actually when they gave it back to me, it had a note inside which I didn't discover for a couple of months, and the next time I looked at the book it said, "This book is great, I'm really pleased, I'm really sorry you've been treated like you have." But as a third year student nurse, wasn't quite sure how they could make a difference. So I don't want to paint a poor picture, but I'm actually doing this to support your point, Terry, and actually the little things are the big things, and those fundamentals are absolutely crucial.
I do think it's really, really difficult because pressures, you know, the last couple of years, staffing, you know, 40,000 nurse vacancies, agency, bank staff. Sometimes on a shift, you are focusing on people not dying. I think that's the bottom line for some acute units. It's drugs, IV. Do you know what I mean? And these things, although impacting significantly on somebody's experience, is not life-threatening at that time. And I think sometimes staff are having to make those kind of decisions, but then they go home and they feel pants because they want to do the other things, but they haven't. And I think that's part of this vicious cycle of recruitment and retention, because, you know, many nurses, you know, we talk to each other, and it's this dissatisfaction that you can't practice how you want to.
Absolutely. My husband talks about that being in meetings for meeting's sake. He says, I could have done so much in that 2 hours that I was just there going, no, we can't do that because of this. No, we can't do that because of that, because I was the person on the front line trying to get this person who's in palliative care where they need to be. So I absolutely understand that. However, we also need to be thinking about the fundamentals feeding into a speedier recovery to move that person into a less acute ward, get that person discharged. And if I'm having food and I'm hydrated and I've got a nice environment and my husband's there and all of those kind of things, I'm going to recover much more quickly and be more communicative, and also be more satisfied and more confident in myself that I can be discharged or I can be moved to the next ward down, if those fundamentals are in place.
Not necessarily these things that take time. I was admitted to hospital in April after a little bit of an accident and ended up doing an overnight stay. Throughout that whole stay, the emergency department, right through to the wards, and nobody at any point actually said what their names were. It was quite nice when it came to the night shift, where actually this was in the hospital I actually worked in, where I actually recognised one of the staff who came over and said hello. But throughout that whole visit, nobody actually, ED doctors right through, nobody actually said who they were. And that doesn't take time.
But let's try and put a positive take on this, okay, on Kate's reflection and how it impacts. Because for me, the positive is one person can make a social movement. One person with focus. Look what Kate has done. Look what she's been able to achieve. So, and all you need, so you can stand up at a festival, everybody else is sat down. You get up, you start dancing. All you need is one follower, one person to get up and start dancing with you, and everybody else will join in. And so I think that we can change things and we can make a difference. So I hear the frustration, but I think that actually the key message and learning for me from Kate is that we can all make a difference. We just need to get that first follower. Donna, you say you love being the first follower, and we can make a difference. So I try to be very positively inspired, despite the fact that there is still an issue globally with people saying hello, my name is, and introducing themselves, but actually I choose to see the positivity of what we can do, and rather than go on, we'll never solve that problem, and not try.
Me too. One of the things that I do, Terry, which somebody else, you guys might want to adopt, the audience might want to adopt from you guys. I do apologise about that gender language. I'm tired. So one of the things I do is I ask their name. So I say, and you are, and what's your name? When they don't introduce themselves, and they go, oh yes, I'm really sorry about that. And sometimes that leads to a conversation about hello, my name is. I wear my own name badge that says hello, my name is, even though I'm not in the NHS. I wear my own name badge because, again, as a person who has a neurodivergent profile, my memory is really poor, and actually remembering people's names is really difficult. If, for example, Donna says, oh, we talked on Twitter about coloured overlays, I'll go, oh, I know who Donna is now. But I wouldn't necessarily, this is just an example, I wouldn't necessarily recognise Donna, if that makes sense. I recognise something that she's done for me, or something that we've worked on together, or a conversation we might have had. So I often say, oh, and your name is? So I've just started a new surgery, and that's sort of some of the things that I've said to them. I'm saying, who've taken my bloods, I says, oh, what's your name? And they go, oh yes. So sometimes we can be the prompt as well.
Yeah. Yeah. Does anybody else have any comments on this subject, or should we move on to another little thing that's a big thing? Ah, Carol. Hello, Carol. Lovely
Hi.
to see you.
Yeah, I gave a talk or a lecture to the medical students at Manchester Medical School, and whenever I give talks, I always mention two things. One's hello, my name is, and the other one is some weird organisation called Fab something. You know the one I mean, don't you?
I know the one you mean.
Yeah. So, but so at the end of it, when it was questions, one of the students said to me, like what you said about hello, my name is, and it's a really good idea. And I'm thinking, yeah, it's so good that people have forgotten about it already in some places. And they said, but having introduced myself to the patient, what do I do next? And I said, well, you just say, what would you like me to call you? And they were saying, how do we start a conversation? And I said, well, it is quite easy, really. You just say, hello, my name is Fred or whatever, and then what would you like me to call you? It's as simple as that. And she went, I suppose it is, really. And I said, it's called conversation, and something that we are tending to forget because everything is being done digitally these days. So I think it's a great shame that hello, my name is being forgotten, and that it was so good when it was first introduced, and Chris is still going all over the world promoting it, Kate's husband. So I think it's up to all of us to keep it going.
So I think it's time we moved on to the next video, so I'll cue that one up now for us.
The day's almost over, the sky's about to show her the first glimpse of gold. Waking up dreams, the thing is I don't know what things that I felt so concerned with, just let go and drift with the breeze. I've been running around looking for answers, and all of these days there still ain't enough. Like the moonlit late plains, let the questions just hang while I need this time with your love. I've been running around looking for answers, but all of these days there still ain't enough. There ain't enough. Time with you, love. Ain't enough.
I think so. Carol, what did that film make you think of personally when you watched it?
I suppose that what it made me think was that there's no knowing who's going to be the next one to go. I mean, obviously with COVID, things have been slightly different, but when you look at it and you've got a husband, a wife and a child, and she's only got 1,000 days left when they've got far more, it is so poignant, the fact that, you know, there's damn all you can do about it if somebody in your family is going to die. I mean, I was widowed at 40. And my husband's parents were absolutely devastated because, you know, it's the wrong way round, isn't it? So, yeah, it was poignant, no doubt about that.
Yeah, and also, I suppose it made me think, if I did think I only had 1,000 days left, what would I want to do? Certainly, spend half of it in a hospital potentially isn't what I'd want to do. Yeah, it's a I find that a very kind of unsettling. Yes. Unsettling thought to have. In fact, I think somebody's got their hand up. Matthew, can you see who
Ellen,
that is?
Ellen, did you want to come in?
Yes, I'm still struggling with my internet a little bit, so excuse me if I come and go. Can you hear me?
We can.
Yeah. I think for me, as a hospital consultant, it also is very telling. It's about quality of life, and it's about not being assumptive as to what you think is an appropriate quality of life for somebody. So the elderly lady in the bed at the end who has 1,000 days left, it's just as important to try and make those 1,000 days excellent as it is as we would if we'd had one of those youngsters in with some other, you know, disease process. And I think it's something that I've noted over the years, particularly recently. And I've lost a close friend of mine from COVID recently. And speaking to her husband on the phone, he said they just see her in ITU as a sort of number in ITU. So I've taken in some photos of who she is. And that's the second time I've heard that. The first time was about an elderly patient, because they said, I want them to know who this person is, you know, to feel that. Not just it's a patient, it's a person with a life. So I think that's what it did for me. And I agree, having reflected the second time with the music, it didn't make a big difference. The only problem is that we didn't know that there was no talking. So you were sort of trying to figure out what do the numbers mean, whereas when the music was there, you were thinking we're not supposed to know what the numbers mean until the end.
Yeah, do you think that that there's the perception that the as you were saying, that maybe the last 1,000 days of an 80-year-old is less important than the last 1,000 days, or making it more than 1,000 days for a 5-year-old? Do you think we have that? We have to make those kind of decisions.
That's a massive. It's a massive ethical question, isn't it? Certainly, I will fight just as hard for anybody, and it is for me all about the quality of life. And recently, I was very proud to get a patient who almost died 4 times in a process of 15 weeks in hospital home, when I had people saying, look, there's no way back from this, you know, we're doing the right thing, but we did get him through it. And you know, the nicest thing that's ever happened for me is that after he was at home, I was recently nominated for the Women's Spire Awards, and just before it, the health board sent me a video, and they'd gone to his house and they'd videoed him at home and his son, and to see that you had a part to play in getting back there, to have that quality of life, to play the guitar like he always had, it was absolutely phenomenal. And that's what drives me. So I think for me, it's not an issue. I think for some people, I don't know, I think they do, you see people differently, I guess, when they're frail and vulnerable, and you automatically perceive that people who've been in hospital for a long time, it takes them a long time to get back to that functionality that you had before, but it doesn't mean you shouldn't try.
Yeah. But I suppose it's also about the conversation with that person about what they want, what they want.
Yes. Yeah, it's got to be a quality of life, isn't it?
Yeah.
It you know, it's as you say, it's about whether they can enjoy life and whether they do enjoy life.
And I think it's interesting. I think Carol raised it about the title patient. What would, you know, this patient in hospital, and actually I'm sat here now, and I might be a patient in hospital tomorrow because I'm going to take the dog for a walk, trip down the curb and break a wrist that needs setting, and I'm going to go to surgery. So we're all patients in waiting. So I think we have to, you have to then turn it round, and because it's almost like it can be used as almost a derogatory term. And it's not, we're all in somewhere or another. We go and see GPs. We're all patients. And so in some ways, the term itself is we could reposition how we think about this, which may then also improve our communication. If we stop with this, I'm the medical and that's the patient. No, I'm one person and that's another person. Let's have a conversation.
Well, I was an inpatient with COVID myself last year in my own hospital with my own friends. I've been a patient a few times, but that was probably the scariest experience for me. But it certainly lets you see what it's like sitting at the other side at all the masks and knowing that you've got certain things outside your door. To tell people to, and it was, it is, we are all patients. And I can still remember the day I had my third child and he went to special care and he got ventilated. And I still remember the day they put him on a ventilator. And I can remember the good communication. I can remember the bad communication and how different that was with different members of staff.
What's quite rewarding listening to that, what you've just said, though, is that you remembered the good stuff before you remembered the bad stuff.
Yeah,
that's a good point. But I think, I'm always saying, if there's ever one message for the new head of the NHS, and that is that we're all people. Don't separate us out into groups that, medical, surgical, gynecology, gynae, elderly, all the rest of it. You're all clinicians, but actually, when you go home, when you take your gear off and you put your mufti on, and then you're all, you're people. And when we leave hospital and go into then we're all people. So let's just remember that all the way through, that we are people. It makes life a lot easier if you do that. And actually, I think your question, Terry, though, about whether or not people, I'm 77, so I got a bit iffy when you said, people of 80, are they treated differently? And I was thinking, I bloody hope not. But the fact of the matter is that the answer is yes, they are. And I'm hearing more and more stories from people who are saying that that's the belief that they have, that once you get to a certain age, you don't get the same treatment. That whether or not that's true is for everybody to work out for themselves. But I think that on occasions that I've seen that it actually has worked like that, and that worries me, because I think these days people are living to be past 100, far more people. It's surprising how many people do get to be more than 100. So to start thinking that just because somebody is elderly and in hospital, then they're on the way out, isn't true. And I think the answer is is to keep as many older people out of hospital as possible.
Yeah, I totally agree with you, and I think it's about services. So whether you would consider that there is the, if you like, financial or development of services that put joined up care for older people who might have comorbidities. So rather than this fractured kind of service where you go one place for one thing, you tell one doctor something, then you have to go somewhere else for another condition, and the care isn't joined up. I think that is very true, Carol, and I think that we haven't got the services right. But I think that there also is on some occasions where there might be very aggressive chemotherapy treatments that an older person, potentially, it would be discussed, may not be able to actually manage that treatment, whereas a 25-year-old would. And again, it's about this quality versus quantity. But I do think you're right. And it was very fortuitous, not that I'm going to draw any attention to his advancing years, but just at that time, Roy Lilly came into the room, and I think he has some very strong views about care of older people.
Well, I certainly do, because I've suddenly discovered I'm now older, and I don't like the language that's used. I don't like the approach that's used. I mean, it's things like this, oh, he's had a fall. Mr. Wilson, he's had a fall. Well, it's so bloody patronising. He hasn't had a fall. He's slipped over.
Or fell off his motorbike, Roy. He fell off his motorbike or his scooter.
As indeed I did. But it's the language. It's the kind of careless ageism that comes into the language. And there are lots of examples of that. But it's typified mostly for me when they say, oh, Mr. Brown, he's had a fall. Like he's had a fall. He can't stand up. He's really stupid. He's old. And I don't think that any services should be planned for older people who can still cut their own toenails. No one should plan services for older people if you can still cut your own toenails, because that's one of the first things that goes for older people. They can't reach down and cut their toenails. And so it isn't until you realise you can't do that you should be planning services. It's a bit like, I always say to GPs, no GP should be a GP unless they've had gout and they've had a baby. And that does sort of narrow the field a bit. But it is about walking in people's shoes. We make a lot of presumptions and talk a lot of rubbish about what we think people want. Actually, they don't want that. They want something quite different. And all of that is wrapped up today in whose shoes and the big things, the little things. I just wish I could get people to try and look at this through the eyes of the people that we're providing the services for. I mean, if you ran a clothes shop, you wouldn't dream of going out ordering 1,000 dresses of something that you think you might like. What you do is you talk to 1,000 customers and say, what do you like? And the whole fulcrum point changes in the health service. In industry, the fulcrum point is balanced so that the customer's opinion, the user of the service's opinion, outweighs the opinion of management. In the NHS, the fulcrum point is the other way around, and it's the managers that know best, and they don't. And so, apart from that, Terry, I don't have a strong view.
Okay, well, that's good to know, Roy. We were talking about this. We just watched the video of from Brian Dolan on the last 1,000 days. So it was thinking about that. And obviously we've also discussed Hello, My Name Is, and about this real treating people like people, not patients.
Yeah, well,
I think
it's very difficult, and I tell you, I do have some sympathy with it, and the reason is this, and there will be health practitioners, I'm sure, in our group, and they'll probably want to say something about this. But it is very easy to slip into a conveyor belt mentality, because if you work on a surgical ward where you do hips, for example, do you remember the days when we used to do elective procedures? Perhaps we'll get back to there one day. But if you work on a ward where all you're doing all day is looking after people who've got a new replacement hip, then you're on the conveyor belt and you just see people, what they're going to go through. They know they're going to come up from recovery. They know they're going to be sore. They know they're going to complain with the physios, make them use their knee or stand up. They know, you just kind of know. And because you've seen 20 of these this week. But for the individual, it's the first hip you've ever had done. And the whole thing is new. And the difficulty is to do it really well is to get the mindset right of the staff in the hospital, so they try and stick with the idea that this is the first time that person in front of them is experiencing what they're going to go through. What the pathway is. Now, the way around that is to try and change the mindset so that you become a care guide rather than a caregiver, as part of the role, caregiver and care guide. So to try and see it through the eyes of the individual, and that is very difficult. It's even more difficult at end of life care, where emotions are heightened and bereavement, it takes over, and you get anger, guilt and blame, and relatives often complain about bereavement services because they're angry that their relative has died. And it's really, really important that we try and focus people's attention and attitude on the fact that this is the first time it's happening to that person. It might be the 50th time you've done it this week, but for this person, it's the first time. I think Carol has got her hand up.
No,
Oh, you're on mute now, Carol.
that makes a change. So I forgot to put it down last time. But I agree with what you're saying, Roy. There's no doubt about that people are categorised in certain groups. I mean, you've got the ward 17. Oh, that's the elderly care ward. Which I suppose it is, but at least most hospitals don't use the word geriatrics anymore, which is good.
Yes, yeah, I agree. It is, but it is difficult. I've got a great deal of sympathy with staff on the wards who are pressured. The one thing that you ask nursing staff, particularly nursing staff, is what they want more of, and they'll say time. Because they all know they want more time to deliver the care that they have a pride in and they wanted to do, because that's the career they've chosen. So it is, we have to try and we can't kind of bury the workforce or the staff on the ward. We can't bury them in this sort of complaint mode thing or the edginess that comes out of this. It's really important that we see it from their point of view. Particularly, I mean, imagine what it was like during COVID, where staff were seeing death on an industrial scale. I mean, if you work in the NHS, you'll get used to the idea that people die. They do. Most of us die in hospital. 300,000 a year of us die in hospital. But in COVID, it was just on an industrial scale. They go in, they look after somebody for a day, then they come in the next day, they'll be gone. So we have a big piece of work, I think, to do with the resilience of workforce and helping them through this mindset thing. I mean, who's on? Donna, you're on the ward still, aren't you? You're still working. Yeah. Am I anywhere near right? Sorry, you put your hand up. Yes, go on.
Yeah. No, it is right. You have got a bit of fucking every day's drudgery when you listen to the ward staff. I mean, the difficulty I've got at the moment is our ward staff have their own them and us, where because the trained staff the patients are so acutely unwell, they're needing a higher level of nursing care. So there's lots more IV antibiotics to be given, lots more complex dressings to be done. So a lot of the fundamental care, learning theory, is on to the healthcare assistants to make sure that patients are their hygiene needs are met and their mouth care is done and they're getting their lunches on time and things. But a lot of the healthcare assistants don't seem to get the message that as a part of a team, we have got the roles. So the ward I'm on, it's becoming quite task orientated rather than holistic, and it's trying to get back to that. Actually, we might be tasked, but we're still a team. So even if you're in that bay and someone next door has a bell running, go and answer the bell. It might be something that they've just dropped their glasses. It might not be a half-hour job. It might be a 2-minute thing, and you've got the time to be able to do that. And actually, as a ward, we need to be looking after everybody. I hate the saying of "it's not my patient," because no matter where you are in the hospital, everybody's your patient. So it's great. Well, my hand was up for going back to Carol's point about the co-design with the patients. In my previous RAMFK, I think it was 3 years ago, I was asked to do a big study about the word frailty. Our new director of nursing came in. She perceived that everybody hated the word frailty. It was classed as derogatory. They wanted the service renamed. When I put my hands out to people to kind of say, actually, how do I go about a co-design? I didn't realise that the CCG had just finished the co-design 3 months beforehand, and the co-design came up with the frailty, because when they spoke to the local citizens and done the road shows as CCG does, they didn't actually care what the name of the service was, as long as the service was there to get people out of hospital, to get them home. So they didn't care it was called frailty. They didn't care what it was done. But since I've left, they've just spent another 2 years renaming the service again. And each time of that was bringing in, as far as I'm aware, there was no patients involved in it, like the CCG did. It was just all the band 7s, the band 8s coming in and coming up with a name. And that must have cost hours of patient care hours, being sat in a room doing workshops with ESIS to come up with a name. And they've now got rid of the frailty part of it. But it just kind of thinks to me, those care hours could have been done so much better, getting people seen in ED and getting them home, getting them supported, rather than sat in a back office having a debate as to what they want to be called. Going through, we've just changed our name from the care of the, I think we were Department of Elder Medicine, so we are now the Department of Older Persons Services, which means my orthogeriatrics team is now the OOPS team, because we're the Orthopaedic Older Person Services.
Oops.
Oops.
Oops, you fell over.
Yeah.
He's had a fall.
He's had a
No. They tripped over. They didn't put enough water in their whiskey.
Now you're talking. Now you've got to grow old gracefully. Yes. No, it is. It is. You know, one of the big. I mean, my background is in industry, as you know, and one of the big things I noticed when I first got involved with the health service is how little we listen to the customer. I mean, when I first came into the health service 1,000 years ago, when I used to come to work with Florence Nightingale on a bike, I'd started talking about customers, and I used to get howled down by people. These are not customers, these are patients, these are whatever. Actually, they're customers, because either they or somebody in their family has stumped up the taxes to pay for all this. So it might be, you know, a second generation paying for it, but they're customers. And I don't see customers as a dirty word. I use customers when I'm writing, and I always have to put it in inverted commas, otherwise I get abusive letters. But we are customers, and we are entitled, I think, to be thought of in that context. The customer isn't always right, of course, we know that, but I do think that services do improve if you ask people what they want. And people, I mean, a large part of Terry's mission in life is getting people to talk about the little things and the big things, and you know, she will tell you, you know, it's what in her nursing experience, what people want is often actually not an enormous change in services. They want the little things. And you know, I remember back in the COVID days, when the girls up in Lincoln, Terry, if you remember, they first brought an iPad into an infection control area where people had unmasked PPE and all the rest of it, and it was who was it? It was Tracy, wasn't it, that brought an iPad in?
No, Sharon.
Sharon.
So they've just started it. So when relatives weren't allowed.
Story. I mean, Sharon. All these people were, terribly ill, and their relatives are so worried. And they got the machines that go beep. They've got the best nursing care, the best medical care. They've got covered in PPE. They're turning people. They're doing every bloody thing they can. But when you actually ask people what they wanted to say, I want to speak to my wife. I want to speak to my daughter. And of course they couldn't. So Tracy brought in Sharon, wasn't it? Sharon brought in her iPad from home, right? And she had to virtually smuggle it in because of infection control, and then the data protection police, and then the confidentiality police. I mean, just about everything that was stacked up against them. She said to this guy, give me an email address for your daughter, and we'll connect you up. She could have said, there you are, I'll talk to your daughter. Boom, revolution. We put it on. Or Terry put it on the Academy of Fabulous Stuff. We all thought the thought police were going to come and close us down. Before we knew it, people were making appeals for redundant iPads, and I think Curry's weighed in with a few, and suddenly people were doing it everywhere. And so, the big thing was not the big clinical push to get people to survive COVID. It was, I just want to speak to my daughter, and it is the little things. And because we've just done Poet's Corner, Terry, you'll be pleased. I've written a poem, and I'm going to read it to you. It's very brief. It says, the little things are the big things. At least that's what they say. But big things only get little when you're far away. The closer you get, the more you can bet. You'll do better, know better, see better in every way. A round of applause, I thought. Yeah. Thank you very much.
I think, has Alex, our wonderful digital curator's got a hand up? Go, Alex.
Hi, guys. I just wanted to gently feed into that narrative from a slightly separate perspective to just sort of add fuel to the beautiful fire. I've sat here fascinated listening all day today. I was on the other end of that for 3 months while my mum was hospitalised during COVID. And my mum the year before was also hospitalised, and due to a few different complications lost her leg. And the second time she was hospitalised, COVID had hit. She had a major stroke which trapped her even further into her body by stealing her power of speech. And so this woman, this very independent firecracker of a woman, now couldn't leave the bed, had paralysis of a hand and couldn't command. She was a former nurse, and she was from a succession of powerful women who were all sisters. And so she held nursing to a very high standard herself and couldn't communicate at all in the ward that she ended up in. And neither were her only relatives, me and my dad, allowed to see her for 3 months in person. She was dying and we weren't allowed in. And it was the compassionate care team and her phenomenal staff in that hospital, which has a bad reputation as a hospital, that allowed my dad and I 10 minutes a day on an iPad, the which she'd talk on, but she could hear. And those 10 minutes, those tiny 10 minutes a day, and those 2 women, because it was 2 women, that did that every day for us for 3 months, I think didn't just perpetuate what was left of Mum's life into joy, but actually saved my life and stopped me killing myself. And that's candid. And listening to not just this discussion, but the conversation before, I feel like I have to reflect on that, because my dad's mental health suffered from the event massively. She was his soulmate. And because of those 2 women, we were able to protect him for that period of time as well. And it goes further than that. The ward staff, they were really hard pressed. COVID was crazy in that hospital. It was rampant. And yet they were able to find a window, and Dad and I would drive there every day, and we would sit outside her window, and they would push her up to the window, and they would open the window, and they would just try for 5 minutes of their day to communicate what she was trying to communicate through the window to us. And whilst that sounds like a sort of hellscape of a situation, that to me was the most beautiful thing that you can conceive, you know. And so the iPad, salvation, and there's no hyperbole, that it wasn't just nursing for the person in hospital, it was nursing for the people outside, you know. So I just thought I'd say that.
Well, thank you. That's an extraordinary story, and I can see it's painful as well. I'm sure we're all enormously grateful for sharing that, because I kind of just reinforces everything we've been thinking about, isn't it? And I'm so sorry you had such a sad story.
But I got to my mum. I got to my mum through that iPad.
Yes.
Yep.
Yes. Well, what we've said is, although COVID was an enormous tragedy for everyone, and people lost loved ones, and indeed people working in the NHS lost colleagues, a lot of good came out of this. And the concept now of being able to do remote visits to hospital is something that will be continued on. And we ran a campaign in the Academy called No Going Back, where there are things like this now that we can do. And we've just kind of thrown the rule bit, because for that nurse to hold up an iPad, you have no idea of the complications that there are in just getting an iPad to a bedside. There's infection control and data and confidentiality, and, you know, it's a palaver. But now that all that's sort of been resolved, and we can do that, so a better service has emerged from it. And I've been talking a lot this morning about people working in the service being COVID custodians. They are the custodians of the things that went well during COVID, and we must respect the past, of course, but take the best of it into the future. And those are the things that we try to capture with the Academy of Fabulous Staff. Terry, I'm going to leave you because I've got to pop into another tent. So
okay, cool. Thank you, Roy. Well, I'm going to follow on with that, because Alex, what you said, I had the pleasure. I met your mum and dad on a couple of occasions, and I can't begin to imagine what that must have been like, separated. You know, if my mother was still living with dementia and was in the care home and I couldn't visit, I don't know what that would have done to me, let alone to her. But I think that also that it's really important that we have a responsibility for the people that have died during COVID. We have to make sure that some of the good things that came out of it, we must carry forward. So your parents did not live around the corner from you. You know, that you often work away. Even now, for you to be able to go and visit on a daily basis potentially would be difficult. Why shouldn't relatives be able to call in and go round on the consultant ward round when the consultant is speaking to your mum, and you can have a plan and discussion with your mum about how to move forward on the iPad? We should do these things, and I think it's through people like this here today and through the Fab Academy that we must make sure that we improve the ability to communicate and be involved in the care of your loved one in hospital. And so I think that's a positive legacy and a responsibility. But I want to tell you what, without a doubt, the nurses, the two ladies that did that for you, without a doubt, it helped them. Because there is nothing, you know, when the feedback now from nurses about the despair that they felt with not relatives not being with their loved one when they were done, were staying after their shift to be there to hold the hand of somebody that was dying, so they would not leave them. They would not be on their own. So the fact that they could do that for your mum actually also helped them. You're saying it helped you and your dad, but without a doubt, that was a really in all the horribleness, that will be the positive thing that carried them through. So it's a win-win for everybody. It's a win for the nursing staff. It was a win for you, and without a doubt was a win for your mum to be able to see your face. Yeah.
These ladies would, with no holds barred, play playlists I sent for her, so that at the very least she and I could listen to the same music at the same time. They thought about that. They thought about those 5 minutes a day. Astonishing amount of care from them.
Yeah. And we must remember that, and part of today is all about sharing that and driving it forward. We have a responsibility.
I think we need to be mindful it's not just in hospitals as well, but also in care homes and shelters. My grand's in sheltered housing, and despite the fact that the office has got internet, it's not in the flats. So her wish list for Christmas was to have a phone that she could video with, and we can't do it for her because she's in a poor signal, so 4G doesn't work. She needs internet. But my cousin's bought her a smart TV that only half works because she can't get Wi-Fi. So it's kind of broadening it out to actually getting the social care aspect and not just health. Going through needs to kind of be addressed as well.